when I first started coming to this conference, we were just starting to talk about what drugs like ketamine and other NMDA antagonists could mean for people with depression, suicidal depression, PTSD. And last year, Leonard Sachs gave me the privilege of standing up and talking about how that ketamine data has come together. The challenge is, what do we do next? Because I think we're learning that although ketamine has been a breakthrough, not only as an initial drug, but more importantly as a whole paradigm for how NMDA antagonists are going to treat depression, suicidal depression, and PTSD, we're also realizing it's not enough, that there is no single magic bullet for these diseases. So, as you know, I'm a used eye surgeon, and we need some real brains behind this. So I've brought my new partner, David Feifel, who has founded what we think is the most effective clinic in the country that's combining these entities. I'll talk about the past and he'll talk about the future. And because we're a publicly traded company, we do need to tell you that we're telling you what we know today. That could change tomorrow. As Yogi Berra once said, prediction is difficult, especially when you're talking about the future. So I will be making forward-looking statements, and please take them for what they are. They're forward-looking statements. But we all know that suicidality and suicide is a national crisis. The reason the editor of the Washington Post gave me the ability to publish this op-ed is because his father hanged himself. And although his father was special as a publisher, his father wasn't special as a victim of this disease, because more than 48,000 Americans died of suicide in 2021. An American dies of suicide every 11 minutes. 12.3 million Americans seriously thought about suicide. 3.5 made a plan. 1.7 million attempted to do it. So we're talking about a disease that takes our best and our brightest. And unlike cancer, unlike infectious disease, unlike vehicular accidents, this is a disease where we've been unsuccessful in bending the survival curve. Every other major disease that kills people in the United States over the last decade, we've significantly bent the curve. We've improved survival. We've decreased unnecessary deaths. And we have yet to do it in suicide. In fact, suicide is continuing to increase. Once a week, I fly a search and rescue mission for the U.S. Coast Guard Auxiliary as an aviator. Just a couple weeks ago, the Commandant of the U.S. Coast Guard stood down the whole Coast Guard for 90 minutes of training in suicide prevention and stress resilience. Why? Because we lost 14 shipmates to suicide last year, and even though we dangled people off of wires over frigid waters, we didn't lose a single person to operations. And the Coast Guard's doing better than the Army, the Navy, and the Air Force. We lose 22 vets and active duty every day to this disease. And the challenge is there's no FDA-approved medication for suicidal ideation. The only FDA-approved therapy for severe depression that includes suicidality is electroconvulsive therapy. It's true that Spravato is indicated for treatment of suicide in people, indicated for treatment of depression in people who are at immediate risk of self-harm, but the label openly says that it hasn't shown effectiveness in treating suicidal ideation itself. There are 125 drugs to treat depression, and every one of them has a black box warning on the label about suicidality. Now, it's true that that black box warning only specifies increased suicidality in younger people, but I can tell you that we have lost two founding shareholders of this company who developed episodes of depression, were put on SSRIs, and within a couple of days killed themselves. We've lost the son of a board member. So I've seen firsthand the extent to which SSRIs rapidly go to akathisia and result in a lethal endpoint. So I've been talking for a long time, and this is work that my brother started in 1987. NMDA antagonists decrease suicidal ideation, and we know a lot about NMDA antagonists in the laboratory at this point. We know that the NMDA receptor can be thought of in some ways as the brake pedal of the brain. If you completely block NMDA, block calcium ion flow through the NMDA receptor, you have thoughts racing out of control. This was originally discovered as the reason that angel dust causes schizophrenia in human beings. On the other hand, if the NMDA channel is wide open, your thoughts are slowed to a crawl, and you have a massive reduction in neuroplasticity. And this was demonstrated beautifully by Connor Liston and his group at Cornell, and it's been replicated all around the world, that at high levels of NMDA activity, the dendrites in the neurons just stop reaching out and forming new connections to other neurons. And some people believe that what you're seeing is a loss of new ideation. On the other hand, if you administer ketamine in this sort of laboratory preparation, all of a sudden those dendrites start sprouting again, neuroplasticity returns, and you can correlate it with clinical symptoms. Similarly, this is work that came out of John Mann's shop at Columbia, where instead of looking at dendrites in animals, you're looking at glutamate and glutamine levels in human patients using MR spectroscopy, where rather than using the magnetic resonance imaging, rather than using the magnetic resonance machine at 7 Teslas to create an image, you're actually measuring levels of molecules. That's called MR spectroscopy. And you can see significant changes in glutamine and glutamate levels in the brain as you administer ketamine in healthy and depressed patients. And you can correlate that with dramatic clinical changes in depression levels and levels of suicidal ideation. So for the first time in the history of neuroscience, we're correlating levels of chemical changes in the brain with clinical symptoms that make sense from a basic science perspective. Now, ketamine is already recommended and reimbursed in the Veterans Administration, and the Kadima Clinic and other clinics that are becoming part of our network already have contracts with the VA, because even though the FDA hasn't approved ketamine for treatment of suicidal depression, the VA's done its own practice pattern, and you can read it online. And we believe that we have efficacy data in hand to support an FDA filing for treatment of ketamine. The French government funded a beautiful study of patients with suicidal depression on an inpatient basis, demonstrated a dramatic difference between ketamine and placebo. And as you know from the recent MDMA failure, FDA says yes, but the problem with comparing hallucinogenic drugs to placebo is you have internal unblinding. So you need to have an active comparator, and John Mann and Michael Grunbaum at Columbia did that study where they compared ketamine to midazolam, demonstrated a dramatic difference in reduction of depression, and then they took the people who were randomized to midazolam who didn't get better, put them on ketamine on an open label basis, and demonstrated the ketamine effect in what had been the comparator group. And most recently, you've seen the PCORI study, where officially ketamine is non-inferior to electroconvulsive therapy because that was the study design. But if you do a post hoc analysis on that data, you'll see that ketamine was actually substantially superior to electroconvulsive therapy. Now, those clinical trials are confirmed by real-world data, and this is data from Osmind, a medical records company that has a large swath of psychiatry clinics as its clients. And this is 20,000 patients worth of data where you're seeing a dramatic decrease in suicidality and depression with ketamine, actually a slightly better effect and slightly quicker effect than you get with nasal S-ketamine. Now, even though there's dramatic efficacy to be had, FDA has warned people about the risks of ketamine, and those warnings are worth reading and paying attention to because they really need to be heeded. Despite its clear benefits, ketamine has clear risks. It's a DEA Schedule III drug. It's neurotoxic if you continue to give it. So the notion that somebody will be on ketamine for months to years is really a dangerous notion in our view. You can turn a primate's brain to Swiss cheese with 90 doses of ketamine at the currently recommended dose. So somewhere in between 1 and 2 doses of ketamine and 90 doses of ketamine is a maximum safe amount, and we need to figure out what that is. Ketamine is addictive. It's hallucinogenic. It can cause acute hypertension, so the notion of giving it at home is a little scary. It can cause vomiting, and vomiting doesn't sound so terrible by itself, but when you remember that this is an anesthetic and can put people to sleep, vomiting in that setting can rapidly lead to aspiration and to a fatal outcome. So the uncontrolled use of ketamine is crazy and dangerous. So that leads us to what do you do next? Because there's no question that ketamine has profound effects. There's no question that ketamine has extraordinarily beneficial effects. There's a very serious question about whether ketamine should be allowed outside of a very controlled clinic setting. But more importantly, how do we combine ketamine with the forefront of neuroscience to produce the best possible answer for patients? And that's what Dr. Feifel is going to talk about. So David, as you know, is a leading psychiatrist. He's a professor emeritus at University of California, San Diego. He's a PhD neuroscientist and knows far more about this than I ever will. David?
Thank you, Jonathan. I want to talk more about a little bit about sort of what it's like to be a psychiatrist in 2025. And I walk around grateful all the time, just being able to be participating in what exciting time this is. I want to take you back very quickly, a little bit of a historical overview of the field of psychiatry. We can talk about the modern psychiatry starting back at the beginning of the last millennium with Sigmund Freud, who actually was a trained neurologist and very much conceptualized mental illness based in the brain. But the technology back then was, in terms of modulating the brain, was very limited. So he developed this whole idea of talking to patients, as a way of bringing about improvements. And the kind of dominating concepts of that whole era was that there are these psychological forces, and there's an imbalance in these forces. And the ego was sort of the superstar, of that era. But starting around 1970, that gave way to a more biological approach. This was the sort of the beginning of what we call the psychopharmacological age, which I think we, for a large part, we still are in. And that was sort of the serendipitous discovery of a lot of the drugs. The first antidepressants was discovered as a side effect of the first anti-tuberculosis drug that was introduced into these sanatoriums, where people were quarantined with TB and just high rates of depression. Suddenly they started to kind of pipe up, and they started to discover, that hey, there might actually be a biological basis to all these mental illnesses, and the guiding principle there was that there's chemical imbalances, which of course today we know is a great oversimplification. Doesn't really kind of ring as true as we hoped it would be. Simply a kind of a low level of certain chemicals, and all we need to do is just rebalance them with these approved antidepressant, antipsychotic, mood stabilizers, et cetera, anti-anxiety medications. And the superstar of that era was serotonin. And then there was this era that was really not fun, starting maybe around 2008, where we had we realized we were really stagnant. Nothing was coming. Nothing really new was coming around. In fact, in 2013, Richard Freeman, a very prominent psychiatrist, wrote a column in the New York Times where he talked. I think the title was something like, an innovation crisis in in psychiatry because there was nothing new happening. In fact, a lot of the pharmaceutical companies were pulling out of CNS R&D because they just couldn't come up with anything that was novel. And it was a kind of gloomy time. I remember going to conferences and people talking about, well, where do we go from here? Psychiatry felt like it was a ship, in the middle of the ocean in the doldrums, and there's no wind taking us anywhere. And then fortunately, it seems like somewhere around 2010, things started to develop. In fact, in Richard Friedman's column, at the very end, he mentions one bright spot. He says, this thing called ketamine, there's been some studies, showing that it has some remarkable effects. Well, ketamine turned out to be the sort of the harbinger of a kind of perhaps the most incredible era to date in modern psychiatry. And for lack of a better term, I call it the interventional era. It's a term that's often being used or kind of has been sort of created to describe a lot of the psychiatrists like myself who focus on these interventional psychiatrists, actually have procedures and interventions that we can do and not actually, necessarily be the kind of full-time physicians for these patients, but hand them back to their psychiatrists refer them to us. We do a course of ketamine, we do a course of TMS or so forth. So it's a very interesting era, and it's really sort of it's an explosion of different modalities that can't be kind of categorized like the pharmacological era where we all focused on these monoamine, serotonin, dopamine, noradrenaline, and it's different approaches and different modalities. And I put a picture of an illustration of the Cambrian era, in evolution, where suddenly, in a short period of time, there was this explosion of all these new forms of life that appeared in the fossil record. So, I believe that's where we are. We're at the very beginning. A lot of psychiatrists still haven't kind of caught on, but I've seen it. I've seen more and more of them and catch on. And there's very few of them now that don't believe in the remarkable revolutionary ability of ketamine and some of the other modalities. So this is very exciting time. And what is the dominating concept here? We've replaced chemical imbalance with connectivity and neuroplasticity, the idea of the brain being able to change and to strengthen connections between different parts. And the superstar molecule here is something called BDNF, brain-derived neurotrophic factor, that everyone talks about. So ketamine was clearly the iconic beginning of this new era, and I want to just illustrate to you the panel. The graph on the right is one of the first studies that gave a single infusion of ketamine. And what blew me away when I read these first papers was you can see the x-axis is which typically in antidepressants is measured in weeks for a benefit. You can see the x-axis are minutes and hours, and ketamine works in minutes and hours. And it's the first time in our field where we can have somebody with serious risk of harm to themselves, and instead of the only option being just basically, hospitalizing them voluntarily or involuntarily to keep them safe, we can actually give them. And I've done this many times. I've averted hospitalization by giving patient ketamine, and within 2 hours, the suicidality is vaporized. It may not be permanently vaporized, but it's just incredible. People just don't feel that existential helplessness. So it's pretty remarkable. ECT has been in psychiatry the gold standard. That's where do you go to when all else fails, and it's been the unchallenged final intervention. And Jonathan mentioned this incredible 5-year study randomizing patients to get ECT or ketamine, which actually showed that ketamine had less cognitive side effects, and actually it was a non-inferiority study. So technically, the official conclusion is it's non-inferior, but actually the magnitude of improvement was larger. This is sort of like the king has fallen. We now have a new best treatment. Now, the problem with ketamine is it's so effective and so popular, and there's such a demand that it's kind of gotten out of control because it isn't. It's for a large part it's a cash market. Insurance won't cover it. Insurance won't cover it because it's not FDA approved, and nobody wants to get it FDA approved because of generally proprietary issues. So we have this really strange situation where people are jumping into it that really shouldn't. I was recently on a CNN podcast with Sanjay Gupta that kind of focused on Matthew Perry tragedy, and it illustrated sort of how this wonder drug is also kind of fraught with all these difficulties. The sign is a sign that I came about at an office building near me, and I think it illustrates how kind of unregulated this is. This is a doctor who's doing pain management, Spravato, ketamine treatments, hair restoration, and aesthetics. It's the kind of person I would not refer a patient with suicidal depression to. The other big revolution is neuromodulation, the ability to directly stimulate areas of the brain and strengthen areas that are underperforming to bring about incredible effects. And it's also in its own way, although it's not as sexy, maybe not getting as much attention, but it also essentially revolutionary, and it's also been shown to be very effective. And there's been huge progress in this technology. We've gone from something that you could only penetrate about a centimeter into the cortex to coils that can go deeper, protocols that can, instead of 6 weeks, can do it in 5 days and bring about remission. And there are other things, and I'm going to run out of time, so I'm going to skip some of these. Vagal nerve stimulation, implantable pacemakers eventually that stimulate the vagal nerve that essentially is a major body input into the brain and therefore modulate the brain. And there was just this week, there's been 2 papers published for a 1,000+ 5-year study showing long-term efficacy. So the FDA has also recently cleared the first digital therapeutic, which is very exciting. Finally, exploiting the fact that everyone walks around with a smartphone to leverage this for therapeutic purposes. And the idea there is these exercises, enhance the connectivity between the frontal lobes and the limbic areas in ways that help emotional regulation. And they've been found to be effective. I won't go through this, but not a huge effect, but it is effective when added to antidepressants. And this is I don't know how well you can actually see this, but this is a map published by by a company called Psychedelic Alpha. It's a website, and it's basically got every company and their product and where the psychedelics, where they are along the pathway to the bullseye, which is FDA approval. And it's just incredible. Talk about a Cambrian explosion. I mean, it's, Kadima, we've gone from 1 or 2 trials in psychedelics to practically our whole research division is preoccupied with this. And it's a completely different paradigm. I mean, this is patients coming in, getting dosed, monitored with therapists, very different from the traditional clinical trials where you give them a blister pack, send them home with pills to take. So what's the future? The future is, in my opinion, is the ability to integrate all these things. We integrate the revolutionary impact of ketamine to really kind of bring it into the regulatory world through FDA approval and insurance coverage, TMS and neuromodulations, digital therapeutics, and all the future treatments like psychedelics and so forth. It's going to be just it's going to be exciting and in some ways confusing for patients, but we need expertise in clinics like the network that Hope is planning to put together in order to be able to kind of have these centers of excellence where people can come and we can deploy all these treatments, the ones that are currently available, the ones that are coming down the road, with expertise in a personalized way to get people the best outcomes and to finally bend this curve on this horrible scourge that is suicide and depression. Thanks very much.